Thank you very much. Can you hear me? Yeah, thank you very much, the chairpersons, and thank you very much for the Diabetes India Organizing Committee for this invite. So the talk I'm going to give today is about what is happening in terms of weight management, the paradigm shift in terms of what we will be doing for our patients in the next few years. I'll start off. So I trained in India as a medical student in Hyderabad, not far away from Nita, and I joined the medical school in 1984. And at that time, if you had a duodenal ulcer or a gastric ulcer, the only treatment that was available was this one, what we call gastrojejunostomy. And I've seen hundreds of them being performed. If the surgeons liked you, they would even assist you. But now, when I speak to the medical students at Birmingham University and talk to them about gastrojejunostomy, they laugh. They even tell me, "Are you a dinosaur?" Because it is a laughable matter. And this has happened in our lifetime. What changed that? A single molecule called the PPI. You can say it's triple therapy or all, but it was a single drug. And within 20 years, it has happened. I think personally that in terms of management of obesity, we are at that doorstep. You may not have the medications, the cost may be higher, but we perhaps have reached it. Let me try and convince you. So now these are two very important, what I would call doctors or practitioners from ancient India, both of them associated with diabetes in some way or the other. Charka, who was a physician, and Shushruta, who was a surgeon, and he devised a lot of surgery. So the question we have to ask ourselves, and even the patient asks, if you want to sort out your obesity, do you want to go to a physician or a surgeon? And most will say a physician rather than going anywhere. I'm sorry for the surgeons in the thing. So why do we concern about? We're talking about a lot of obesity. This is just a slide to say you the seriousness of the issue. 2.5 billion obese, 890 million people are living with obesity, corresponding to 16%, 80% cases of type 2 diabetes. So obesity is big. But one of the other things whenever I give a talk in Indian context, Sharad asks who wants to be obese. The answer is yes. A lot of people in India at some stage wanted to be obese because obesity culturally was associated with prosperity. And the reason for that is this J-shaped curve when it comes to obesity. Once your weight drops to 19.5, your chances of dying actually tends to increase. So when we talk about getting thinner and thinner, we always have to be careful because the balance is very very small between 19.5 to 25. Because either you go, if you look at malnutrition, which we had in this country few decades ago, your mortality is increased. There is the Lancet Commission on Obesity, which has come up with a new definition. You may agree or disagree. We can actually debate about it. But from a South Asian context, it is very important because it is now talking about adiposity rather than BMI. And this was specifically important in terms of the metabolic parameters that we use in terms of South Asian diabetes or Indian diabetes. Because here we are not only talking about the actual BMI, because you will not find a South Asian or Indian with a BMI of 50 or 60. They're hardly any. The only ones with a BMI of 50 in an Indian context will be a woman, sorry, who's very short and fat. But otherwise, you don't get these massively obese people. And the reason for that is once your BMI goes about 40, your pancreas packs away and you start losing weight and you start developing type 2 diabetes. So therefore, recognizing obesity or adiposity at a subclinical diagnosis, which the Lancet Commission is doing, and putting in strategies to stop that and treating it early is perhaps the option. Sharad mentioned this. Obesity is not something an individual can be blamed with. This nonsense about lifestyle advice, change the lifestyle. You got. I always say that perhaps, especially in the British media, the most discriminated people are people with obesity, and that's the reason because there is the blame. Now we know that there are perhaps the four reasons for obesity, probably more hypotheses. One is the slow burner who doesn't burn the fat. One is a a hungry brain, a hungry gut, or something to do with emotional things. So almost all cases of obesity can be explained with some issue. Now let's try and turn to a bit of science. So what happens when we try and eat, and how does it matter? So basically, in the hypothalamus, you've got two centers. One is controlling your hunger, the other, or what we call the feeding center, and the other is satiety center. Once the signal usually comes through the nucleus tractus solitarius, through the vagal nerve, and there are a number of peptide hormones or nutrient stimulated hormones that control our appetite. Among them, the ones that make you hungry are ghrelin, which probably can make you eat a horse or a camel, whatever you want to eat. Then you have got things like leptin and insulin, which have got a kind of a loop back role. And then you have things like GLP-1, PYPP, oxymodulin, which actually decreases the appetite. So if you're thinking about a drug that can actually make you lose weight or eat less, this is just you've got to have a pro peptides or pro hormones of the ones in the middle, or anti to the ones on the side. So how do we achieve weight loss? So to achieve weight loss, there is lifestyle, there is pharmacotherapy, and there is drugs. So let's address the lifestyle. So if you look at this study about maintenance of weight loss after various lifestyle intervention, this meta-analysis, you get about 5 or 9% after 2 to 3 years. So it works. It works in some people. Should always be tried, but the evidence base for that is not very strong. What about medication? When it comes to medication, there have been a number of anti-obesity medications since 1893. We are trying it. So everything has been thrown from thyroid to rainbow pills, and most of these have been associated with adverse outcomes, and therefore they have gone out of loop. So what do we have now, and why are we excited? So what we have now is what could be coupled together and called novel nutrient stimulated hormone based therapies. And these have been developed and in pipeline for obesity. These includes injectables and oral therapy. I'll go through the chief ones. Most of them are in phase 3. Some of them are available now in the UK and the US. The first ones we had were the GLP-1 receptor based agonist, liraglutide or Saxenda. So this is for weight management, was there, and there have been the scale trials which have shown the efficacy of about 10% weight loss in a third of the patients. Then we had semaglutide at a higher dose of 2.4 milligrams subcutaneously in the forms of Wegovy. We have got this in UK, approved by NICE, used extensively in private practice. Again, 10% weight loss achieved in about 50 to 60% of the patient. I use that as a cutoff. Then now we have got these dual GLP-GIP combination. Tirzepatide or Manjaro has been launched and is available in the UK. With tirzepatide, you're talking about a weight loss of 10% in 90% of your cases. Then you've got dapiglutide, maritide. Then you've got the newer ones, the ULP, GLP-1 and glucagon combinations. There are the triple receptor agonist with GLP, GIP, and glucagon. Retatrutide is the main one, which is undergoing trials. I'm going to present some data published in New England Journal showing some amazing results. Then you have got the endopancreatic receptor agonists like cagrilintide, amylin, and the other very exciting drug is this one called the CagriSema, which is a combination of cagrilintide and semaglutide, which is being developed by Novo Nordisk, and again it has shown some very good results. So all these are injectable once weekly. Then you have got the oral GLP-1 agonist, which are being developed. Oro Orforglipron is one of them, which is very exciting. So a lot of things happening. So how do these agents work? So let's quickly look at Manjaro or tirzepatide, which is a dual GLP-GIP coagonist. So in terms of the actions of the GLP, we know it acts on the central nervous system, increases satiety, decreases food intake, causes nausea, and decreases body weight. GIP, it again decreases the food intake, decreases nausea, and decreases body weight. In pancreas, it increases insulin, decreases glucagon, GLP-1, while GIP increases insulin and glucagon. Uh, GLP also decreases stomach emptying. But what is interesting is the role of the GIP has on the subcutaneous tissue. This is being studied in various studies, and there's some very good, interesting publications coming on that it somehow kind of recalibrates the adipose tissue. There is a thing about that whether it burns the adipose tissue, but clinically you're seeing weight loss, and especially the weight around the viscera, so that the waist circumference actually starts decreasing, and again the other effects on the liver and the skeletal system. So what is becoming obvious is the GLP and GIP are acting together. So they're not only decreasing the appetite, so they're controlling the diet, but they're also burning the fat. So they're doing the lifestyle for you. So as there was a famous Indian actress who says, if I don't have a thing, the doctor will give you. So this is if you can't do physical activity, this is what your doctor can give you. So how does it work? So if you look at so we start Manjaro at 2.5, increase the dose on a monthly basis, go up to, the target is to go up to 15. Depends upon the tolerability. The main side effect is nausea and vomiting. So when I started on my patient, if I say nearly 70% of them are on 5 or 7.5 or 10, very few, only about 20 to 30% reach 15 milligrams. And the weight loss we are getting is about 12.4 kilograms, which I think is very good. But one of the things that you got to remember, and this I always say, is that when we talk about clinical trials, is very different from the clinical practice because I'm a clinical academic. So in a clinical trial, when it says the average weight loss is 10 kilograms, so 12 kilograms, it is only talking about the mean average. Most patients in this trial, about 80% of them will lose some weight, but out of those 80%, you may have 30% of them who will have massive weight losses. The others may have modest, and in some of them, there may be no weight loss. Now, in any weight loss drug or any weight loss program, if you want to show the significance, once you reach 20%, that is when you don't need bariatric surgery. So this is the data from retatrutide, which is in the phase 2 trial published in New England Journal of Medicine. And you can see that your patients have started hitting 22%. With Manjaro, tirzepatide, nearly 50% of the patients will lose 25% of the body weight. So you are reaching that target of 20% where bariatric surgeons becomes threatening. And this is a kind of meta-analysis of all the new drugs, and you can see a few of them have started reaching 20 to 22%. So we are perhaps entering a phase where these medications and these drugs will completely change the management of obesity in the next 3 to 5 years. And this will perhaps be that moment when we start moving the paradigm shift from bariatric surgery to oral medication. So this is a schematic drawing of how things will probably look in 5 years in our obesity practice, and you could see this whole gamut of drugs that are there, and then depending upon how they will be used or which pathway. So, is this all just talk and bluster, or is there data to support it? So one of the best ways to really look at whether a drug or a new technology is catching up is to look at markets. Because I think the markets always get it right much before we as scientific doctors do it. So if you look at the incretin sales, so in the US, between 2020 in 2023, when you compare to 2022, the products of the GLP sales of Novo Nordisk were nearly 89% higher. During this period of time, between 21 to 22, bariatric surgery, which is probably a place where most bariatric surgery is run, the numbers have come down significantly. Although they are still increasing by 6% when compared to previous growths, the growth has not happened. The sales of these three anti-obesity drugs was nearly $21 billion. This is just the US market. Manjaro, which was launched about a year or half into when the data became available, the sale is $5 billion. So you can see there is a huge market. And is estimated by 2030, the global market for obesity medication will be 144 billion. So if you're planning your retirement pots, this is where the money needs to be. And it is estimated 9% of the US population, 9% will be on anti-obesity drugs by 2035. Tirzepatide, Manjaro, has recently been licensed by NICE, and as you could see, the license or the authorization is pretty widespread. So our current estimated is that if NICE guideline, which is mandatory to be implemented, it will cost the NHS 10 billion pounds. 10 billion pounds. So there are costs attached. So my final two slides. So I have got two patients. So this is one of my patients who was actually in ITU because he couldn't breathe. He had type 2 respiratory failure, OSA, BMI of 60. Now, this patient, and this I'm talking about 8 or 10 years ago, we had to get this person out from the ITU, get him on a VLCD diet, make him lose some weight, and he had a gastric bypass. And this is post surgery. Him and his wife has actually gone into the court. So we could do it to the surgery. And this is my another patient who had the similar experience of losing about 60 kilograms, but this time we did it with Wegovy. So that is what we are actually seeing in clinical practice. Thank you.